Respected panelists, moderator, dear participants, welcoming you all
Karan,
to my talk on FECO in compromised Rexis. Thanks, Scientific Committee and Dr. Parthas.
डुप्लीकेट स्लाइड कर देना.
Rexis is most important for completion of FECO. It should be central, circular, appropriate sized, covering
पूरा
360
का
degree
पूरा
IOL optic and
डेस्कटॉप.
continuous. It is so important that no Rexis, no FECO. If in
So
doubt,
yeah,
continue
start.
FECO in torn. Do not continue FECO in torn Rexis. How frequently it occurs? According to different literature, it varies from 0.79 to 5.5%. However, operative Brexit TR is a reality due to one or more reasons. What to do if Brexit is torn? Do what is best in your hand, and prime target is safety of patients. In torn Brexit, options are closing the eye and refer to a competent surgeon, or call an experienced surgeon if available. Do not continue against the odds and ends up with dropped nucleus. Depending on the skill and experience of the surgeon, availability of the correct instruments, OBD and appropriate IOL, we can convert to SICS or ACC, performing supracapsular phaco in iris plane or AC or mixed, or continuing endocapsular phaco. If we decide to continue phaco, certain factors are to be considered, like type of cataract, white, hypermature, intumescent, pediatric cataract, etc., location of the tear, timing of the tear, primary, secondary, or spontaneous, presence or absence of comorbidity like pseudoexfoliation, zonulopathy, etc. In primary tear out, that is before starting hydroprocedure and phaco, take care not to do any maneuver that may extend the tear to a posterior rupture. Phaco and IO maneuver away from the torn area to be done, increased phaco power during sculpting, and decreased fluidic parameters. Avoid AC fluctuation throughout the procedure by injecting dispersive OVD. IOL haptics should be placed 90 degrees away from the area. Here is a video clip showing Rex's extension in sub-incisional area, and retrieval attempt uh, may not be successful. Uh, I think like that, and another tear is initiated from the opposite side and ends near the initial tear. Viscoelastic was injected. LRI incision was given to correct less than 1 diopter astigmatism. Then viscoelastic is again injected with phaco tip using power. A triangular nuclear fragment from the distal part of the intact capsular area, bag is fashioned, and the nuclear fragments is removed. Viscoelastic is injected in the bare capsule, and also in the adjacent area viscodissection is done. Gentle viscodissection is done, and the nucleus is rotated, and the nuclear fragments are removed by using a vertical chop, and gently the nuclear fragments are removed one after one, and after clearing the nuclear part, viscoelastic is injected using coaxial IA. Cortical cleaning is done, and in the tear area, bimanual IA is used to clean the remnant cortical matter, and the IOL is implanted in the bag. It was a trifocal panoptic IOL, and the haptics are placed in the bag in such a fashion that the haptics are away from the torn area, and viscoelastic is cleared off, the wound hydration is done, and the eye is closed. After 2 weeks, the vision was 6/6 and N5. Here is another video in hypermature white intumescent lens. On attempted rhexis and aspiration of the liquid cortical matter, there was sudden extension of the tear to the periphery. Cortical matter was aspirated, liquid cortical matter was aspirated, and by using phaco tip, the debulking of the nucleus was done, and the nuclear fragment from the intake bag area is removed. Then, using a venous scissor, the rhexis is initiated in the distal part, and using a rhexis forceps, the rhexis, I am trying to complete the rhexis in the distal part. It is like a hemorrhexis. Then, after completion of the rhexis in the distal part, there was sufficient space, and I inject viscoelastic and then clear the remnant nuclear fragments by using phaco, and then injecting the IOL into the bag. And the IOL is, I am trying to place the IOL in such a way that the haptics of the IOL remain in the intact area of the bag. And after placing the IOL in the bag, then bimanual IOL is used to clear the remnant cortical matter. Wound hydration is done, and the eye is closed. Here is another video of hypermature cataract. Here also, during rhexis beyond the subincisional area, there was extension of the rhexis, and it seems the rhexis may not be successful. Then another tear is fashioned from the opposite area. It was it ends up to the previous initial torn area, and now with phaco tip, a triangular triangular fragment is fashioned in the distal area of the intact part of the bag, and proper depth and width is done, and the nucleus fragment is emulsified and aspirated through the phaco tip. The nucleus is rotated into the bag, and then it was not a very hard nucleus, so fragmentation and emulsification was easily done using low parameter phaco. And after clearing the nuclear fragments, viscoelastic is injected, and the remnant cortical matter is cleared using coaxial IA. After completing the cortical clearing, viscoelastic is injected, and the IOL is implanted in the bag, and the haptics are placed about 90 degrees away from the torn area of the capsule. Wound hydration is done, and is closed. Here is a video showing surgeon is trying to complete the rhexis with cystitome, but on injection of the viscoelastic substances, suddenly the cystitome goes behind the equator and touches the posterior capsule. Another surgeon come and gently remove the cystitome from the eye, inject viscoelastic by using micro scissor. He is cutting the floating part of the capsule, and then remove it with capsulorhexis forceps. Then viscoelastic is injected, and phaco is completed using low parameter of the phaco. After removal of the uh, nuclear fragments, it is seen that there is a tear of the posterior capsule by the cystitome. Viscoelastic is injected, and then triamcinolone is injected to stain the vitreous tag, and bimanual anterior vitrectomy is done to remove the vitreous tag, and also to clear the cortical matter from the remaining part of the bag, and then a three-piece IOL was implanted in the sulcus, and after placing the lens in the sulcus, the myotics is injected to constrict the pupil, and the eye was closed normally. Here is another video showing flux. The setting of the femto laser was faulty due to new engineers. They and it was overlooked, and during laser application you see that the capsule is shattered into pieces like lens fragments, and trypan blue staining was done, and the surgeon, after injecting viscoelastic with micro scissors, is trying to remove the multiple capsular tags, and by using Rexis forceps is trying to complete the Rexis as much as possible, though there is extension of, of the tear in peripheral areas. As there was femto fragmentation of the lens was done, so it was not difficult to remove the nuclear fragments. Gently, one after one fragment were cleared, and after removing the nuclear fragments, viscoelastic was injected using bimanual IA. The cortical cleaning was done, and the IOL was implanted in the bag, and it was possible to maintain the IOL in the bag. Viscoelastic was cleared, wound hydration done, and the eye was closed normally. Here is another video showing the primary rexis was normal, and there is no problem in the rexis, and hydrodissection was
Michael, how much time left?
done normally, but it was a soft cataract. During removal of the cataract with phaco tip and second instrument, somehow there was
Michael,
a
can you hear me?
tear, secondary tear in the rexis margin, and after removal of the cortical matter, it is seen that right side there was a tear extension, and then the IOL was injected normally in the bag, but it was a toric IOL, so care is taken to place the IOL in the bag, and before final placement, the care is taken to clean the viscoelastics from the anterior chamber, and no attempt is done to remove the viscoelastics from behind the IOL. After removing the clearing the viscoelastics, the wound hydration is done and overhydration is avoided. After 1 month, it was seen that the IOL position was 75 degree as it was targeted preoperatively. And in conclusion, I want to say that with proper precaution, appropriate instruments availability, OBD and IOL, phaco is possible in most of the cases in Rexis extension. Thank you all for your kind attention.